Hi everyone, my name is Heather Mayberry, and I'd like to provide an overview of my Doctor of Nursing Practice scholarly project entitled Perceived Benefit of an Intraprocedural Central Line Insertion Checklist. Before we begin, I would like to acknowledge and thank each of my committee members recognized here. As I am sure many of you are aware, central lines are an invasive device placed in the central vasculature. They are an essential component of management of critically ill patients in the intensive care setting. The Agency for Healthcare Research and Quality indicates that 48% of patients in the ICU require placement of a central line. Central lines, however, do present the potential risk for device-related infection. These infections, known as central line-associated bloodstream infection or CLABSI, occur when there is microbial transmission of bacteria into the bloodstream. This is identified microbiologically and defined by National Health Safety Network criterion. Considered a hospital-acquired condition, CLABSIs compromise patient safety, potentially leading to increased hospital length of stay or even death. As I'm sure you can imagine, this contributes to substantial rise in costs to health systems. A considerable rise in CLABSI was detected in the ICU setting of the proposed project facility over the course of 2021. A majority of the CLABSIs confirmed were identified within 7 days of central line placement, which represents a potential correlation with insertion practices. This discovery necessitated investigation into strategies to enhance central line processes. The project was proposed in multiple forums to project facility stakeholders and gained much support as 2022 commenced. The purpose of this quality improvement scholarly project was to determine the perceived benefit that ICU staff find in use of an intraprocedural, evidence-based central line insertion checklist during bedside central line placement, as opposed to not using a checklist. The primary aim was to enhance the perceived benefit of central line insertion checklist use during bedside central line insertion. Secondary aims included a reduction in procedural deviation with subsequent increase in patient safety, prevention of patient harm, decrease in insertion-related CLABSIs, and cost savings to the hospital. A literature search was completed using multiple healthcare-related databases. Boolean operators, truncation, and exact phrasing were used to blend combinations of keywords. This initially yielded approximately 7,000 results. Appropriate limiters were then employed to filter articles for relevance and applicability. A final total of 22 articles were included in integrative review. The articles were examined for commonalities, and these themes were identified. Multiple studies included appropriate clinical indications for insertion of central lines, including reliable vascular access for the delivery of total parenteral nutrition, high-risk medications, and delivery of blood products, as well as the provision of hemodialysis and hemodynamic monitoring. Several sources confirmed that patients requiring central lines have an increased risk for development of CLABSI secondary to the anatomical insertion site selected, the number of central line lumens used, and general hospitalization requiring ICU stay. Evidence collectively indicated that CLABSI is avoidable with implementation of evidence-based practices focused on specific elements of central line insertion care, including hand hygiene, proper insertion site selection, and appropriate catheter utilization. Multiple sources stated that incorporating a checklist to guide central line insertion enhances the mutual awareness of the procedural team, improving the quality and safety of patient care, as well as overall patient outcomes. Inslee's theoretical framework for situational awareness was selected to underpin this scholarly project. It originated in the field of aviation and was founded on 3 levels of situational awareness consisting of perception, comprehension, and projection. Perception involves the collection of pertinent information from the environment at a specific time. Comprehension involves blending and processing current information and pre-existing knowledge to formulate an understanding of the importance of elements gleaned from a situation. Projection allows for the prediction of future circumstances based upon accurate surveillance and interpretation. This framework was found to best fit this scholarly project as a central line insertion checklist provides a tangible tool that stimulates the situational awareness of the care team to perceive inconsistencies that may jeopardize patient safety. It also facilitates an understanding of its implications and allows for the accurate prediction of possible patient harm. This project was elected to employ a quantitative descriptive design. It took place in a single ICU within a rural hospital in Virginia. The project sample consisted of 2 independent dichotomous groups of ICU registered nurses, advanced practice providers, and physicians. Inclusion criteria consisted of registered nurses, advanced practice providers, or physicians 18 years or older that were eligible to participate in bedside central line insertions for admitted adult medical ICU patients prior to August the 26th. Exclusion criteria consisted of non-licensed or ancillary medical ICU staff or medical ICU registered nurses, advanced practice providers, or physicians hired after August 26th. Participants could not engage in project activities during bedside central line insertion in any other inpatient unit or when a central line was placed in any location other than at the bedside in the pilot unit. Meticulous preparation, ensuring patient and participant protection, facilitated the achievement of institutional review board approval from both the project facility and Maryville University. This allowed the project to commence on August 22nd, beginning with participant recruitment. Participants were recruited through distribution of an invitation and implied consent document. For those voluntarily choosing to participate, the invitation included instructions for access to an anonymous electronic pre-intervention survey. This survey was created to evaluate 12 elements of perception using Likert scoring to quantify perception. Responses were presented in a consistent positive or negative directional pattern with a score of 1 indicating an extremely negative response and 5 indicating an extremely positive response. After baseline perception data collection, a mandatory educational presentation was given on 2 separate occasions on August 31st and September the 2nd. In order to preserve the quality and consistency of information delivered, the primary investigator was the sole presenter. The presentation included the purpose and significance of the project, as well as details regarding checklist completion. Following project participant education, the checklist tool was implemented on September the 5th. The tool selected was the Johns Hopkins Central Line Insertion Checklist. This highly reliable tool was utilized in the Keystone ICU project, which included 103 Michigan hospitals and resulted in over a 60% CLABSI reduction in 3 months that was then able to be sustained for 4 years. It is publicly accessible on the Agency for Healthcare Research and Quality website. It includes a concise, valid list of the most pertinent evidence-based steps for use in concurrent observation of central line placement. Over the course of 1 month, the tool was used by staff of the pilot unit during all bedside central line insertions. After the checklist implementation phase, an anonymous electronic post-intervention survey, identical to the pre-intervention survey, was distributed to staff beginning October the 10th. This allowed for the collection of voluntary staff perception data following checklist use. Following data compilation and analysis, results revealed that 14 checklists were completed during the checklist implementation phase. Each checklist had 12 steps, equating to 168 total steps observed. Of those, you'll note in the table that there were 2 instances of procedural deviation detected. The pre-intervention sample consisted of 29 participants, while the post-intervention sample contained 31 participants. Optional anonymous demographic data collected offered information regarding sample gender, age range, and role of each independent population. The pre-intervention sample consisted of 17 females and 12 males, with females accounting for 57%. The post-intervention sample was comprised largely of females at 81%. The sample varied widely in age between pre-intervention and post-intervention, with the largest percentage of participants between the ages of 18 to 30 and 31 to 40. The pre- and post-intervention samples were comprised of a majority registered nurses, with 64% in the pre-intervention group and 84% in the post-intervention. Interestingly, the pre-intervention sample contained 7 advanced practice providers, equating to 25% of that sample, while only 1 participated in the post-intervention sample. Demographic information was also collected regarding the sample population's overall years of experience in healthcare. Pre- and post-intervention samples were well distributed, with the largest percentage of participants with between 0 and 5 years experience and 16 or more years experience. The sample was further examined for staff years of experience assisting in central line insertion. As with the general years of experience, the largest percentage of participants surveyed in both samples had 0 to 5 years experience participating in central line placement or 16 or more years. The statistical package for social sciences version 28 was used to perform Mann-Whitney U testing on the responses to the 12 anonymous electronic Likert-style perception survey questions. These questions encompassed the various elements of perception shown here. A p-value of less than 0.05 indicated statistical significance. As you can see, no statistically significant difference in perception was found for the first 11 survey questions, although question 12 indicated a significant staff perceived benefit in integration of a central line insertion checklist into the hospital's electronic health record. Despite the lack of statistical significance found in the other elements of perception analyzed, a shift in extreme positive perception post-intervention was noted. It was also noted that pre-intervention perception of checklist benefit was actually higher than originally anticipated. Checklist completed during procedural observation provided descriptive insight into staff engagement in checklist implementation, along with compliance with recommended central line insertion practices. Optional demographic data was also collected that yielded general sample characteristics. Inferential analysis using the non-parametric Mann-Whitney U test evaluated the degree of statistical change in each element of perception following checklist implementation. It achieved this by comparing the means of the two independent dichotomous groups with ordinal data of the dependent variable. The Mann-Whitney U was most suitable as it relied on minimal to no assumptions regarding distribution of data or specific parameters of the ICU staff sample population. It analyzed each pre- and post-intervention perception survey question with an average effect size of 0.3 achieved. The project's findings continue to reinforce the use of a central line insertion checklist to guide staff in the appropriate completion of central line insertion practices. This aids in CLABSI prevention, fostering patient safety and harm prevention. The meticulous planning, preparation, and implementation facilitated fulfillment of project aims, which were in alignment with current guidelines and supported the project facility's goals for quality and safety. The marginal statistical significance detected may have been attributed to the higher degree of staff perceived benefit of checklist use pre-intervention. Despite this, there was a positive shift in staff perception discovered, demonstrating enhanced perception of the checklist tool. Analysis revealed consistent staff participant engagement in checklist implementation. It also uncovered minimal deviation from recommended procedural steps, correlating with 0 CLABSIs being identified on the pilot unit during the course of the project. Project limitations included a small sample size and short duration. This may have influenced the project's power and effect size, adversely impacting the generalizability of the findings. Response and observation bias may have also been present during participant procedural observation, as staff relationships may have affected the reliability of checklist completion. A barrier to project completion was a delay in university IRB approval that resulted in a narrow time frame for recruitment and pre-intervention perception data collection. There were also fewer central line insertions during the project period, which may have reduced staff's exposure to the checklist tool. Unit short staffing may have also negatively contributed to staff motivation to participate in project activities. In conclusion, the findings of this project indicate that ICU staff find meaningful value in the use of an intraprocedural central line insertion checklist. Although statistical analysis revealed only minor significant change, it demonstrated a positive shift in staff perception and a desire for checklist implementation into the project facility's electronic health record. This supports the ability to locally generalize and sustain this practice, as well as implies the need for formulation of policy that standardizes checklist use during central line placements. Results suggest that checklist use augments staff perception and procedural compliance, subsequently enhancing the quality and safety of care, as well as strengthening CLABSI prevention efforts, which lead to healthcare cost savings. Recommendations for future research include longer periods of data collection, as well as larger and broader settings. This will potentially aid in the ability to generalize findings outside the confines of this study. Future inquiry should also focus on determining if specific checklist elements are more consistently associated with central line insertion procedural deviation, as well as the effect of checklist use on overall CLABSI incidence. Thank you so much for taking the time to review this scholarly project, and here are the references that I utilized. Thank you so much.